This is a 3-hour workshop. We're very pleased and honored to have a visiting professor from the University College of London, Dr. Benjamin Gardner. He's here with our school for 2 weeks. This is his second week. And some of you may have attended his workshop or his talk on habit research as it relates to behavior change. And Benjamin has kind enough to offer to do a workshop specifically talking about workplace health promotion and behavior change, because all of us spend a lot of time at workplace, and because of that, it's a captive audience for behavior change. As you know, Singaporeans have some of the longest working hours in the world, and so what better place than the workplace to change health behavior. Even though Ben will be looking at physical activity, he will use it as an example to illustrate how some of the principles can apply to other aspects of behavior change in the workplace, whether it's dietary or mental health and so on. And I'm very glad to have Ben do this talk. I'll let him, I'm not going to introduce him because he has a very diverse and a very versatile background in terms of research, so perhaps he could spend a few minutes introducing himself and share with us today's schedule. Thanks, Ben.
Thank you very much. So thank you very much for inviting me here. It's a great privilege to be here, and I'm particularly thrilled to see that people have turned up for the workshop. That's always a good start. My own background, I'm a social psychologist by background, by training. But following my PhD, which was in social psychology, I then moved to health psychology, and the kind of work that I was doing as a social psychologist was to try and understand why people do things that are not always in their best interests or not in society's best interests, and what we can do to actually change that. So just kind of taking those insights and imposing them within health psychology is or the transferability of those insights to public health is actually what took me into health psychology. My own interests, primarily I'm interested in psychological processes underpinning people's behaviours, why people do what they do, how we can use understandings of why people do what they do to change what people do. But of course this also brings in the notion of how we can change people's behaviour, which is why I'm here, and I'm going to be hosting this workshop today on workplace health behaviour. So the aim of today's session is to share some of the expertise that we have at University College London when it comes to health psychology and when it comes to behaviour change. I sit within the Health Behaviour Research Centre within UCL, which is a department which is well populated by health psychologists such as myself, and we try to develop interventions to get people to engage in healthier behaviours. I'm also affiliated with the new UCL Centre for Behaviour Change, which is a more multidisciplinary affair and draws on the expertise of everyone at UCL who's working within a discipline that's relevant to behaviour change. And I'll be saying more about that later on. Now, I don't know how many of you are here because you read the abstract for the workshop and thought that sounds interesting, I'll come along. I must say to those of you who did that, I have a couple of confessions to make. First of all, there is simply too much to say about how to change people's behaviour within a 3-hour workshop. One of the things I will be advertising at the end of this is the summer school that's being run at University College London, which is open to everyone across the globe, on how to understand and change people's behaviour. Now that summer school is an entire week full-time, so we're talking 35 hours. I can't really distill that into a 3-hour session, but I'm going to try my best. What I'm going to cover then is not the entire the entire body of knowledge around what determines workplace health behaviour and how to change it, but rather more generic principles of behaviour change and how we can use those how we can apply those to workplace health promotion. The abstract also discussed the notion of sedentary behaviour, nudging and the built environment. Don't worry, I haven't misled anyone. Everything that I mentioned in the abstract will be covered, but actually this is going to be more a generic talk on behaviour change, and it's going to be over to you to try and apply what I'm saying to workplace health behaviour. So with that in mind, I thought I should probably change the title of this. First of all, as has been mentioned, I was going to focus mainly on physical activity, but then I thought actually the people that are coming along today might not necessarily be interested in physical activity, so I thought, why don't we change the title to just Understanding and Changing Workplace Health Behaviour? But then I thought, actually, this is kind of applicable outside the workplace. Understanding and changing health behaviour. Actually, if we're talking about behaviour change more generally, we don't even need to focus on health behaviour. So this is a talk about understanding and changing behaviour more generally. This isn't just a talk, though. This is an interactive workshop. The way it's going to work, there'll be a series of short talks from me, and then there will be group activities, because there's no point in everyone just listening to me without actually trying to apply some of this stuff. You'll see when the group tasks come, because I've actually coloured the slides slightly differently, so that should be a cue for you to start working in groups, but we'll come on to that later. So here's a general overview of what I'm going to be talking about in the structure of this session. First of all, what behaviour is when it comes to health, and why it's important for our health to understand behaviour and try to change behaviour. Then I'm going to be covering what intervention developers within public health tend to do when it comes to developing behaviour change interventions, and the problems with what public health intervention developers tend to do, before moving on to a more systematic approach to behaviour change. And this is the main focus of this session today. I'm going to be introducing what's called the behaviour change wheel approach to intervention design, which has been developed at UCL, and a basic model of the core determinants of any behaviour, whether that's workplace health behaviour, any other workplace behaviour, or any behaviour whatsoever. I'm also going to be touching on the notion that before we do any behaviour change intervention, before we can think about changing behaviour, we need to engage in what has been termed a behavioural diagnosis. In other words, what is the problem here? What do we understand about the problem? What do we know about the problem from all relevant sources, and how can we use that to change behaviour? Having done this behavioural diagnosis, you then need to think about the options that are available to you when it comes to behaviour change interventions. And I'll be showing you within the behaviour change wheel approach, there is information that can lead you from your analysis of what the problem is to the most appropriate intervention options. As I said, this is only a small part of the behaviour change process, but hopefully it will give you kind of introduction to what we're doing at UCL, a taste for what we're doing, and also it will set you on the path to developing interventions that are most likely to be effective. If there's time, I'm also going to touch on the importance of running a rigorous evaluation of any intervention, though I may skip over that depending on the time that we have available. If anyone has any questions during the time that I'm talking, let me know, jump in, put your hand up. I'm aware that I talk very quickly, so let me know if you'd like me to slow down. Okay, so first of all, why should we be interested in behaviour? Here is a set of statistics that were published in 2009 from what the authors called a comparative risk assessment. So this was a study of all deaths within the US in, I think it was 2006, and what the authors did was they looked at those people who were exposed to known risk factors for death and disease. What would happen if they simply weren't exposed to those risk factors in any way? So that allowed them to quantify the relationship between particular behavioural risk factors and all causes of death. And here's what they found. Now I find this quite startling. Tobacco, smoking, accounts for 1 in 5 of all deaths in the US. And this isn't specific to the US. This seems to generalise across the Western world. I apologise, all of the examples I'm going to be drawing on are from the US and UK. Now the reason I find this startling is, this isn't 1 in 5 of all smokers, this is 1 in 5 of all people who die as a result, directly or indirectly, of smoking, whether that's actually smoking themselves, passive smoking, or problems associated with smoking. Likewise, being overweight, which we know to be a problem of energy balance. Too much energy in, not enough energy out, that accounts for 10% of all deaths. I'm not going to focus on all of these, but if you add up these statistics, they add to over 50%. So in other words, if we could stop people from engaging in behaviours that are bad for them, or get them to start engaging in behaviours that are good for them, we'd be able to prevent many deaths, or rather prevent early deaths, extend life for a certain period, which would have profound benefits for our nations, for our economy, as well as for the individuals themselves. So this is why it's important to do work to try and promote health behaviour change. And just before we Move on then, what do we mean by health behaviour? Here's a definition that my colleagues and I drew up a few years ago. We view a health behaviour as any activity that may help to prevent disease, detect disease and disability at an early stage, promote and enhance health, or protects from the risk of injury. Something that's particularly notable about this definition is it doesn't imply that you have to be doing a particular behaviour for health reasons. So it might be that I like to go walking, for example. The reason for that is not because I think that it's especially good for me, although it is. The reason I like it is it's more about a kind of sense of freedom. So I'm not motivated by health. Nonetheless, because I go walking and walking affects my health, I am engaging in a health behaviour. Now the kind of opposite of these is, the opposite of the health behaviour is the health risk behaviour. Now that's any behaviour which essentially has an opposite effect. So any activity that hinders the prevention of disease, hinders the detection of disease and disability at an early stage, and so on. So we can fundamentally think of two different types of health-related behaviour. The health-promoting behaviour and then the health risk behaviour. Health behaviours that help our health and behaviours that put our health at risk in some way. So when I talk about today behaviour change within the workplace, those are the two basic types of behaviour that I'll be talking about. And when it comes to behaviour change, we can be talking about promoting health behaviour or discouraging health risk behaviour, or often some combination of the two. So what are the most relevant behaviours in the workplace? Well, I actually assume that you probably know which behaviours are most important, which is why you've turned up to a workshop on how to change workplace health behaviour. But just a kind of overview of some of the behaviours that struck me as being quite relevant within the workplace. I don't know what it's like here, but certainly in the UK there's a kind of culture of eating at your desk. Often people do this mindlessly. If you're doing a particularly difficult task, or actually if you're doing a particularly menial, repetitive task, you often kind of just eat in the meantime just to pass the time. It's something that's quite enjoyable to compensate for the fact that you're sitting at work and you're not enjoying yourself. So what we eat and drink within the workplace affects our health in that it affects our risk of becoming overweight, which in itself is a health risk factor. Smoking, it seems from my observations of Singapore that you're not allowed to smoke in the workplace here. Nonetheless, there's probably a kind of productivity deficit from people going out to smoke, so taking smoking breaks. If nothing else, as a non-smoker, I can say it's quite unpleasant when someone comes back into the office having just had a smoke, so that's not so much a kind of health outcome, but it's nice for other people to not be exposed to that. And we all know that smoking causes death and disease. Something else that is often neglected within the literature when it comes to workplace health promotion is health and safety behaviours. These are the kind of behaviours that we do within the workplace that we need to do in a particular way so as to protect our health and do them safely, such as lifting heavy objects and so on. As was mentioned at the start, Singaporeans seem to work a lot longer hours than most people, and in fact that counts as a health behaviour in itself. Too much work, not enough play. We need to make sure that we have a proper work-life balance and don't work too hard, because we know that overworking is a risk factor for stress, and that in itself has health consequences. When people are stressed or under stress, they have less capacity to fight disease, and there's actually interesting studies showing that when there was this one study that showed that students who went along to a lab and essentially received some kind of, I think it was a pinprick or something like that, they were intentionally wounded by the experimenter, and they then they took a measure of students' stress levels. Those students who were stressed before receiving this actually took longer to recover from that particular wound. So we know that stress is bad for our health. I want to focus today mainly on physical activity and sedentary behaviour. I'm sure you all know this, physical activity is good for your health. The more you do, the better it is for you. But I just wanted to spend a few minutes talking about a kind of new passion of mine. Well, sedentary behaviour isn't my passion, the desire to change sedentary behaviour is my passion, but I just want to explain to you why this is important, because it's only in the last 10 years or so that people have begun to realise that this is a problem. The reason I'm going to be talking about this is I'm going to be drawing on it as an example of some of the behaviour change work that I'll be discussing later. Now I've called sedentary behaviour the new workplace health risk behaviour. In fact, it's not a particularly new behaviour, it's just, as I said, only relatively recently that it's become recognised that actually the amount of time that we spend sitting And not doing physical activity in the workplace is in itself a risk factor for health. Now it's important that we draw a distinction between physical activity and sedentary behaviour. Often within the research literature and within everyday language, they're used to mean the same thing. If someone is sedentary, it means they're not doing enough activity. But actually there's a more sophisticated definition now within the research which describes physical inactivity as not meeting the recommended guidelines for physical activity, in other words, not doing those 150 minutes of moderate to vigorous physical activity that you should do each week. And then there's sedentary behaviour, which is something different. And sedentary behaviour refers to anything that you do when you're sitting or lying down that involves minimal energy expenditure. The reason this isn't so important is that actually many desk-based workers, well, first of all, a lot of people in the modern world work in an office at a desk. And the time that they spend sitting is essentially just sedentary time. The reason that I think it's important that we draw a distinction between sitting, sedentary behaviour, and physical inactivity is that there's growing research to show that these are two independent risk factors for our health. Because even when, in the epidemiological research, even when researchers control for the amount of physical activity that people do, there's still a relationship between the time that they spend sitting down and various health outcomes, such as, well, general all-cause mortality, cardiovascular disease, cancer and diabetes. The reason that that's so important then is actually, if you look at what most intervention developers think about doing within the workplace to counter the fact that most people sit down too much, is they try and encourage them to do more activity during their lunch breaks. Or they give them incentives for signing up for, say, physical activity sessions at their local gym after they finish work. But what this research tells us is, actually, even if someone is highly active in their spare time, if they're still spending a lot of time sitting down at work, then that in itself is still, it's causing a problem for their health, and their physical activity isn't compensating for the time they spend sitting down. So this has spawned a lot of work in which I'm quite interested to just get people to sit less in the office and perhaps stand a little bit more. The reason I said, as I said, that I'm going to be, that I mentioned this is one of the behaviours that I'm going to be drawing on throughout this particular workshop. Oh, and also I have some really nice data on it actually. This is data from a study that's ongoing at University College London called the Active Buildings Project. Now the Active Buildings Project is about trying to understand how the office environment kind of works as a correlate of people's physical activity and sedentary behaviour. In other words, what are the characteristics of a particular workplace that seem to lead it to be associated with either time spent sitting or time spent standing or time spent walking around. And I'll be touching on this later on. But for now, this is just quite a nice graph based on accelerometer data. So based on giving office workers something, a little device that sits on their thigh and can tell whether they're standing, sitting or moving around. The office workers in this study were asked to wear the accelerometer continuously for 1 week, and that allowed the researchers to look at how long on average people are sitting down versus standing versus moving around. Okay, this is quite a small sample, it's only 72 office workers, but there's no reason to suspect that it should differ across the typical office environment. What this graph shows us is that on average, the average person in this study is sitting for around 18 hours every single day. That actually includes time spent asleep, but even if you remove that, and so let's say they slept for 10 hours, that's still 8 hours that people are sitting down elsewhere in their average day. So clearly people are sitting down for too long, so we need to do something to change that behaviour. And just getting people to be physically active in short bouts is not sufficient to change that. Okay, now the first thing that I would like you to do, and I don't want you to spend too long doing this, I'd like you first of all to get in a group. Now the group that you get into, I'd like you to stick with that group for the rest of the session, so make your choices wisely. I'd also like you to choose one particular health behaviour, and I know this will seem like quite a vague task, but I just want you to come up with, for that behaviour, some ideas on how you would change that behaviour. The reason I'm doing this is so we can review this later on when I've gone through everything else. So don't worry, you don't have to do this in a great amount of detail. I'm just interested in, having not actually sat through the workshop, what are your initial ideas on how you would change that behaviour? Does that make sense to everyone? Okay, so we'll have about 10 minutes for that. Is that okay? Also, hopefully you've got your own pens and paper so that you can write down your ideas, because I am going to ask you to come back to this later on. Also, I'm not going to ask you to share your ideas with anyone, so whatever you want to write down is fine by me. And do feel free to turn around, make yourself comfortable. You don't all have to just look in front. Is there any groups that, can I just do a quick show of hands? Who's chosen which behaviour? Group over here. What's your chosen behaviour?
We have a lot of conflicts. I think our previous are not sedentary.
Sedentary behaviour, okay. You're going for sedentary behaviour. That's good. But the first group I went to seems to have gone with the thing that I thought was most interesting. Well done. Okay, second group.
Water consumption.
Water consumption, interesting. Group at the back. Food and drink. Sedentary, 2 for me. Good. What's that, sorry? Snacking, okay. 2 food, 2 sedentary. And group at the front? Sedentary, okay. Fantastic. So 3 groups have already been persuaded by a couple of slides on sedentary behaviour. 2 groups looking at kind of food and drink or snacking, and 1 group looking at water consumption. Now, as I said, I'm not going to ask you to tell us what your ideas are so far, but does every group have some kind of idea of how they would go about changing this? At least an early idea. Okay, that's fantastic. Now, I'm going to ask you to come back to your idea later on. But the aim of that task was, just as I said, to have something that you've written down that you can then come back to, having kind of been exposed to the rest of this particular talk. Now, when it comes to behaviour change, this is how it's traditionally been assumed that we change behaviour. It's traditionally thought that actually, if someone isn't doing a behaviour that's good for them, or they are doing a behaviour that's not good for them, it's because they don't know that their behaviour is important and it's playing a role in their health. So actually it's assumed that this follows a kind of inoculation model, whereby it's assumed that if you want to change someone's behaviour, you just give them information on the importance of doing the behaviour, or not doing another behaviour. And that should lead to behaviour change. Now obviously I'm going to be critiquing that approach, but here are a couple of posters. Unfortunately they're quite blurred here, but here are a couple of posters from a genuine workplace health promotion campaign that I found that kind of follow this approach. The first of these, I should say I don't know whether these were effective, so I'm not holding them up as examples of bad practice, but they seem to typify for me that information-based approach. This was presented in a booklet that's available on the internet about how companies go about changing their workers' health behaviours. And it seems that for food and drink, it's assumed here that if you give people information on what they should be eating each day, in other words, their guideline daily amount of given nutrients, then that should cause them to adopt a healthier lifestyle. Here we have a poster here that says about love your lungs, look after your lungs. It mentions the proportion of people that are affected by lung disease, and clearly there's this implicit message that the way to love your lungs and look after them is to be physically active. So these are very much health-based messages. They're very much based on giving people information. Here's another campaign that I particularly like. This doesn't so much apply to the workplace unless you're thinking perhaps, I don't know how it works here in Singapore, but in the UK and the US we have the kind of end of the year office party where people tend to drink too much. This is a genuine campaign that was run in the UK that tries to emphasise to people that this is all they think about when they're going drinking, how much fun they're going to have, when actually this is how your night will end up if you drink too much. So again, it's based on information. Here are the dangers of doing this particular health behaviour. And by giving you information, it either changes your mind or it reminds you of something that might not have been so important to you at the time. Now what I want to cover now is this notion of what's been termed an Islagiat intervention. The reason that we use this term, Islagiat, is that it kind of captures how most intervention developers arrive at their interventions. It stands, well, I'll tell you what it stands for in a second, but the point that I'm making here is that actually every time we develop an intervention, we have to make assumptions regarding the nature of the problem that we're trying to change and how we can go about changing it. But very seldomly do we articulate those assumptions, nor do we test whether those assumptions are actually true or whether they have any grounding in reality. And this is where the Islagiat principle comes in. It stands for it seemed like a good idea at the time. So this is the only basis by which a lot of people design interventions. They think, actually, this looks like a good idea, I'm going to give this a go. So it might be based on their own kind of rudimentary analysis of what they think the problem is, or they might have some brand new idea that they want to impose on a particular behaviour. But that's quite different from actually doing a rigorous analysis of what the nature of the behavioural problem is. And surely we can actually do better than this. Rather than just saying, I've got a hunch that this will change behaviour, we must be able to do something better than that. And this is where the health psychology and the behaviour change work actually comes into play. Now I mentioned that there are assumptions that underlie every intervention regarding what needs to change and how you go about changing it. Now some assumptions that underlie those interventions that I've just shown you, those post-it campaigns. Let's think about this. One of the assumptions is that actually employees may not realise that that particular behaviour affects their health. For example, the notion of saying, love your lungs and look after your lungs, the assumption there is that people don't know that physical activity is good for their lungs. They also assume, not so much the drinking campaign, but the other two actually assume that health is the most important thing to the individual. And if you say to them, look, you should do this, or you shouldn't do that because it will affect your health, then that will get them to change their ways. The problem there is that health is not always an individual priority. In suggesting that employees value their health, another assumption is that from an employer's point of view, or from an intervention developer's point of view, the employee or the target of your intervention actually has the same values as you. So for example, if you give them information telling them this is good for your health, you're assuming that that person values health just as much as you do. If you give someone information saying actually you're going to have a good time drinking tonight, but you're going to be sick later on, you assume that they actually see that as a bad night. Unfortunately in the UK that's quite a good night for many people. And lastly, by giving people information on what's good for them, we assume that people are rational and deliberative. In that they see that information, they think that's relevant to me, I'm going to spend some time reading that information and I'm going to take it in and then I'm going to adapt my behaviour. But that's not always the case. So these aren't the only assumptions that underlie these interventions, but they're important assumptions. And we need to ask ourselves when we come up with an intervention, on what basis have we made these assumptions? First of all, whose assumptions are these? Are they your assumptions as an intervention developer? Are they based more on kind of rigorous evidence that you have regarding what's important to the individual? So with that in mind, I'd like to spend a few minutes now, if you go back to that intervention that you just came up with, I'd just like you to write down or start to articulate some of the assumptions that have gone into that intervention. Does that make sense for everyone? Yeah? Or no? Okay. Alright, so we'll have about 10 minutes for that. So just to reiterate, I'm asking you to go back to the intervention idea that you just drew up, and then I'd like you to think, what are the underlying assumptions regarding what you think needs to change to bring about a change in behaviour, and how it can actually be changed. And this, does any group want to actually share what their intervention is and what their assumptions are. I should point out that the aim of this is not for me to come along and say actually everything you've assumed is wrong. It's just for you to start thinking about what your assumptions are and to articulate some of those. Does any group want to actually share this with the others? Yes.
We were doing sedentary behaviour in
Yes.
office, and so far I'm not sure in terms of, we know there is an independent factor, but exactly how long is too long a sitting down time, and therefore if our assumption of breaking up sitting down time, say every hour you stand up and do something 5 minutes or 10 minutes, is that good enough to lower the risk?
Yeah, the evidence on that is very shaky, as I understand. The best that we have is a study that showed that limiting sitting to only 20 minutes at a time, and then between those 20-minute bouts, doing either low intensity physical activity or more moderate intensity physical activity, that was good for you. But actually that was focused on both sedentary behaviour and physical activity. So we don't have the evidence yet about how long you should, well, what the kind of maximum amount of time is that you should sit for. But most behaviour change intervention developers, I guess, that I speak to just go along with that 20 minutes message. But actually, yes, the evidence isn't that clear on the time. I suspect, and this is pure speculation, but much like physical activity, it's probably the case that the longer you do it, the less good for you. So it's kind of up to you to find that optimal point at which to intervene. I think this group were about to say something, is that right? Great. So some willing volunteers. So what were your assumptions? Because I did hear you saying, okay, so we've assumed that. Are you willing to share them?
Yeah, I guess we're similarly talking about sedentary behavior, about people sitting for too long.
Yeah.
And I guess the assumption that we had with why people sit for too long is that they're conforming to the norm because everyone else does it, it's the norm, so we continue to do that.
Excellent, excellent. So your assumption is that actually people are doing it because other people around them are doing it. And actually that's what I like about that idea is it's not what would probably come to mind for a lot of people, which the first thing they think is, well, they don't know that it's not good for them. So actually, yeah, I really like that. So your assumption is actually it's about the social environment, and so presumably if you are to change the social environment, that will bring about changes in the behaviour. Any other group have one or more assumptions that they'd like to share? Yes.
So we've been looking at water consumption. The basic assumption is that the basic assumption is that we feel that people either do not drink enough at all, or that they substitute water with other fluids, like sugar-sweetened beverages or coffee or whatever you can imagine. So this is sort of our underlying assumption. And then we don't have one intervention. We have come up with a few different sort of potential ideas for interventions. Some are having the underlying assumption that people don't know that water consumption is good for their good for their health potentially. Some of them are related to they don't have access to water, or access to other drinks is actually easier than water specifically. And then we have one which I find quite interesting, that a status symbol, like if you have a cup like a Starbucks cup or something like that, or a coffee mug, it's sort of a nice cup, but there's nothing like that for water. So we felt an intervention could be to give people a nice cup or a nice mug for their water with a lid on top. And this is sort of the underlying assumption that you need a status symbol or some kind of symbol which shows water consumption. I consume water and it's great.
Okay, that's brilliant, thank you. What I really like about that is this notion, actually what you've just described is moving from that initial assumption. You did describe quite a few assumptions, but the core assumption there, in terms of informing your intervention, is that the coffee cup from Starbucks is a status symbol. Therefore, in order to change the behaviour and to bring about water consumption, you need to substitute the coffee cup as a status symbol for an equivalent container for water that can also serve that status symbol function. The other point that you made that was really interesting was that you assumed that actually when it comes to behaviour change, the problem here is twofold. People aren't drinking enough water, and the reason for that The other behaviour that you need to change is that they're drinking, for example, too much coffee or too many sugar-sweetened beverages. So there we see some fundamental assumptions about what the behaviour is, what other behaviours are relevant to it, and how you can go about changing it. And actually, among your assumptions regarding why people do the behaviour are quite different from your assumptions over here. And the point of this exercise is to show that actually these are based on your own assumptions regarding that behaviour. Because you chose two different behaviours, it's not so easy to kind of combine those and say, look, you've come up with different solutions to the same behaviour. But you can imagine that you could have said, if you were doing a water consumption intervention, you could have said, well, we think the reason that people don't drink enough water is because everyone else is drinking a Starbucks. So you see, potentially you can come at exactly the same problem, but because your own preconceptions of what needs to change are different, you arrive at very different intervention ideas. And crucially, it may be, for example, that only your intervention works whereas yours doesn't, or vice versa. So the point, as I said, of that exercise was not to claim that everyone's making the wrong assumptions, but just to point out that you do have your assumptions, and typically that is what informs intervention design. But we need to move beyond our own assumptions, our own preconceptions, and start thinking about what the evidence tells us about how to change behaviour. Now, if we're thinking about behaviour change, the first question we need to ask ourselves, the first question we need to ask ourselves is, what is the behaviour that we're trying to change? And what I liked about your example is I said you had two behaviours in there potentially. One is water consumption, the other is coffee consumption, or sugar-sweetened drink beverages. Consumption of those. So you need to specify what is the behaviour that you want to change. Then you need to ask yourself, what determines that behaviour? Because there's no point in trying to come up with something to change the behaviour if you don't know why the behaviour is occurring or why it isn't occurring. So what I'm going to draw on now is a very, very basic framework that explains why people do what they do. This is it's a model that would typically be described as being about action stages or action phases. What this model suggests, again, it's very simple. This isn't the best we can do in psychology. It suggests that there are two stages before anyone takes action. First of all, someone must be motivated to take an action. In other words, they must want to do it. They must need to do the behaviour. After they've formed the motivation stage typically culminates in some level of intention or desire or willingness to do the behaviour. Now, after they've arrived at that intention, people must also have volition. In other words, they must be able to do everything they need to do to make their good intentions become a reality, to act on what they intend to do. And only if those two things are present will you get action. As I said, it's a very basic model. But the reason that it's so important is that you need to think about at least two different reasons for why people might not be doing the behaviour that you want them to do, or why they might be doing a behaviour you don't want them to do. And depending on where the problem lies here, that should inform the type of strategies you use to change the behaviour. So if the problem is one of motivation, for example, people don't know that it's not good for them to sit for so long, then you will need to give them you will need to use different techniques to change the behaviour than if the behaviour is one of volition. So to give you an example, as I said, someone may simply not be motivated to stand more at work, and they might just want to sit down all day at work. In that case, you could give them educational information saying, look everyone, here are the problems associated with sitting. It might be though that you have another group of people who fully realise the dangers of sitting too much, but actually they can't stand for whatever reason. Now that might be about physical problems. For example, they physically cannot stand for long periods. Or it might be that they have competing priorities. For example, they've got a paper that they need to write before the end of the day, and they don't have time to keep standing up for the sake of their health, and they're prioritising something else. But the point of what I'm saying here is that you need to use different strategies according to what the cause of the problem is. Is it about motivation, or is it about volition? And those campaigns I was talking about based on information only target motivation. They don't do anything about volition. So how do you go about targeting volition? Here are some behaviour change techniques which map directly onto that volition process, or that kind of volitional stage of action. Within psychology, we also call it the self-regulation stage, the stage at which you are able to actually act on your own wants, desires, and wishes, and so on. So here are 4 strategies that you can use. One is to form a plan. It's a really simple way of changing behaviour, but if you want to, for example, do some physical activity next week, you should make a specific plan about exactly when you're going to do that physical activity. Because that, in a way, just commits you to doing something. Rather than saying, I'm going to do some physical activity at some point next week, you should specify exactly what physical activity you're going to do and in exactly what context. So instead, I will go for a swim next week at Tuesday at 8 PM at home. Another technique that works for changing, that works for the kind of self-regulatory stage is self-monitoring. This is where you simply ask someone to monitor what they do. It's surprising that actually many people don't know that they're doing things that are bad for them, or they don't keep adequate records of any progress they make when you're trying to get them to do something new. But by getting people to keep a record of what they're doing, it can keep them motivated. So it's a volitional strategy that can actually feed back into motivation. The way self-monitoring works is essentially you kind of get a source of feedback on what you're doing, but you administer it to yourself. If you tick a sheet every time you do some physical activity and you look back at the end of the week and see you've got 15 ticks, you think, actually, I've done quite well this week. So it's kind of self-driven feedback. An alternative is to get feedback from someone else. So thinking about physical activity in the workplace, it might be that someone else, or you may be fitted with, say, an accelerometer, or someone monitors how much activity you do, and at the end of the week, the employer invites you in and says, well done, you actually did 3 more hours of walking around the office this week than you did last week. Lastly, reviewing behavioural goals. You can set yourself a particular plan of action, but you need to make sure that you keep going back to that plan of action and making sure that you can actually achieve what you do. If there's too much of a discrepancy between what you plan to do and what you're actually doing, then it's likely that you'll stop doing that thing. So the point of what I'm saying here is just to show you that there are techniques which are associated with the volitional stage of behaviour. So ways to change behaviour that don't involve giving people information. And actually there was a really nice paper published by my colleagues at UCL a few years ago now, which showed that these techniques are the most effective techniques for changing people's diet and physical activity. This was based on a review of 84 studies that had been done, 84 intervention trials, whereby the researchers coded each of those interventions according to whether they used those 4 techniques, and they found that those interventions which use self-monitoring were the most effective ways, they were the most effective interventions for changing physical activity and diet. And actually, when self-monitoring was combined with either action planning or reviewing goals or some form of external feedback, the effect of the intervention was almost twice that of interventions which didn't include these techniques. So what does that tell us? Well, for me, it tells me that actually people don't need to be told about the importance of diet and physical activity. Surely everyone knows it's good for them by now. I think we've reached saturation point with that message. And in fact, what we need to do is start training people in the techniques that they need to act on their good intentions. And it also gives us the more basic message that often people need volitional support, not so much motivational support. So we need to move away from simply giving people information. Now the 2 stages that I just talked about, motivation and volition, that kind of model is a very, very crude model of human behaviour. And when it comes to behaviour change, this is by far the most important framework for changing behaviour. It's called the Behaviour Change Wheel, and it's a relatively new framework for understanding and changing behaviour that's been drawn up by Susan Nickey and colleagues at UCL. If there's only one thing you take from today's workshop, it should be the importance of the Behaviour Change Wheel. If you Google Behaviour Change Wheel, note the UK spelling of behaviour. It's important if you're Googling it. This paper published in 2011 is open access, so anyone can look at this paper for free. It just goes through everything to do with how you can understand and change behaviour, and it's so important. There's also a book that's just recently been published on actually how to use the behaviour change wheel, but I'm going to talk you through the very early stages of doing that. Now, the behaviour change wheel, what you can see from this is there are 3 layers. The first is about the determinants of behaviour. So it's a very basic framework that tells us why people do particular behaviours. And once we know why they do their particular behaviours, or why they're not doing another behaviour, we can understand what needs to be changed in order to bring about the change in behaviour. Something else that the behaviour change wheel does is, the second layer of the wheel is actually about the functions that interventions can play in order to change behaviour. And I'll be coming on to each of these in more detail in a second. What's novel about the behaviour change wheel is, it offers a way of combining what we know about what needs to change with the ways in which we can change behaviour. So we can move through the intervention design process in a very systematic way. The third layer of the wheel is about policies through which we can implement the intervention that we've designed. I'm not going to talk about that today because I'm not going to assume that everyone has access to policy levers within this room. So I'm only going to focus on the determinants of behaviour and intervention functions. But let's start with the determinants of behaviour. This is called the combi model. Within the UK, it's a kind of bit of a joke. The combi boiler refers to a boiler that you have in your house that is a combination of well, I don't really know what it's a combination of, but nonetheless, it's a play on the word combi. What this states is there are 3 essential components that go into any behaviour. For someone to do a particular behaviour, A, they must be capable of doing that behaviour. B, they must have the motivation to do that behaviour. And C, they must have the opportunity to do the behaviour. This will probably seem really basic, but it's really important. The reason that it's important is it gives us this basic framework for understanding people's behaviour. It also tells us that if there is a problem that requires a behaviour change intervention, then the behaviour that needs to be changed, if it's something that people aren't doing, the reason they're not doing it is that they either lack the capability or the motivation or the opportunity, or more than one of those elements. Now, if there's a behaviour that people are doing that they shouldn't be doing, then the problem, then what you need to do is actually try and dismantle some of these, change their motivation, remove some of the opportunities, or in some way kind of reduce their capability for doing it. So what I'm going to be arguing today is that when it comes to developing any intervention, you need to go through what's called a combi analysis, in other words, using this to analyse the nature of the problem at hand that you're trying to solve. But before I do that, each of the elements of the combi model, well, apart from the B, each of the elements of the com can be broken down into 2 further subcomponents. In terms of capability, someone must be physically capable. Applying this to physical activity, there's no point in trying to get someone to be more active in the workplace if they have some kind of physical disability that means that physical activity is not suitable for them. People must also have the psychological capability. And what that refers to is being able to engage in the thought processes that you need in order for behaviour to occur. One of the most famous kind of capability-related variables is self-efficacy, whereby people must feel confident in doing a particular behaviour in order to actually do that behaviour. Within the component of opportunity, that can be broken down into 2 as well. There's a physical opportunity. In other words, the environment must be such that it allows you to do the behaviour. And there should also be some kind of social opportunity, or rather, there shouldn't be a lack of social opportunity. In other words, there shouldn't be any social norms that actually prevent you from engaging in a particular behaviour. Lastly, motivation can be broken down into 2 components. One is reflective motivation. That's based very much on our conscious reasoning side. It's based on the stuff that's accessible to us in our heads about why we should do behaviours and so on. And then there's the non-reflective or the automatic motivation. And that refers to the kind of processes that energise our behaviour but that that kind of bypass our conscious thought processes. So acting on impulse, acting out of emotion, and so on. So to reiterate this important point, these are the 3 key components of any behaviour. And any any behaviour change intervention process must start with an analysis of which of these needs to be changed in order to bring about behaviour change.
Ben, can I ask?
Yes.
When some people talk about concepts like self-esteem and the ability to self-actualize, is that relate to C or M?
I think that would probably come under capability, because it's about thought processes that you can engage in, not necessarily that you need to engage in, but if you engage in them, then it facilitates the behaviour. So that notion of self-esteem, self-actualization, that all potentially works in making us feel that we can do a behaviour. So it's not about it's more a kind of internal cognitive state that determines whether or not we feel we can do a behaviour.
Okay, thank you.
Okay, so now we're going to move on to this notion of doing a behavioural diagnosis. 2 stages to this. First of all, you need to think about what is the exact behaviour that you are trying to change. Then having thought about that, and just to dwell on that point, it's really important to think about what the behaviour is that needs to be changed in order to kind of focus your intervention on a particular problem. If you've just said, well actually, we need to change physical activity, you haven't really done a good enough behavioural diagnosis. Physical activity can be thought of as a category of behaviours. Walking is a physical activity, running is a physical activity. When it comes to sedentary behaviour, we're increasingly seeing standing as a form of physical activity because it engages the muscles and works as a balance activity. So it's more muscle strengthening than sitting down. So when you conduct your behavioural diagnosis, you need to think, first of all, what is the behaviour, the precise behaviour that you're trying to change? Having done that, you then need to use that model to think, well actually, why aren't people doing this behaviour? Or why are they doing the behaviour that you don't want them to do? And just to clarify, I forgot to mention, this notion of a behavioural diagnosis, the way to think about this, the way that Mickey and colleagues talk about this, is that if you were a physician and someone came to you with symptoms, you wouldn't just give them some pills and say, take these. You'd first of all have to speak to them, find out what more about the nature of the problem before coming up with your not best guess, but actually based on the evidence in front of you, what you have most confidence in as a treatment for that particular problem. And this is essentially applying that exact same principle in a way that many intervention developers don't do to changing behaviour. So first of all, what's the behaviour you want to change, and then what needs to change in order to do that. And this is the first thing that you should do. So just to give you an example, I mentioned that I'd be talking about some examples in terms of sedentary behaviour. So this is my own behavioural diagnosis when it comes to office workers' sedentary behaviour. The reason I put what is the desired outcome, often when people try and change behaviour, they think about the outcome of behaviour, they don't think of behaviour itself. So they might think, well actually, within this office there are a lot of people who are overweight, so I'm going to develop a behaviour change intervention to make people lose weight. Well great, you might be able to do that, but weight and weight gain is not a behaviour, it's an outcome of behaviour. It's through, as I said, eating too much or not expending enough energy that you gain weight. So if you start from a particular outcome, which might be a reduction in sitting time, you then need to think, okay, but what's the behaviour that's going to lead to either an increase or decrease in this outcome? In other words, what are the behaviours that need to change? Well actually I can think of 3 behaviours that are relevant here. One is that people sit for too long at their office desk without taking a break. Another is that actually people should be standing more in their office. And lastly, it'd be nice to encourage people to walk from their desk to other areas. So you can see we've moved from a desired outcome to types of behaviour, or specific behaviours that we might want to change. What I'm going to do here is I'm going to focus on just one of these behaviours, because often it's better to think about one specific behaviour to change rather than a multitude of behaviours, and see how you get on with that. So my example is standing in the office. Okay, so that's my behavioural problem. What's the diagnosis? And yes, full marks for the gentleman standing at the back. It's interesting actually, I've been to quite a few talks where they talk about the importance of standing and not sitting so much, and everyone kind of smiles and says, oh yes, we should stand more. And in fact, I went to this talk where the Director of Public Health England said, please feel free to stand during this talk. No one stood, apart from me actually after a while. Anyway, I'm mistaken. So, this is my behavioural diagnosis of the reasons for why people might not be standing in the office. Is it about capability? Not really. The office workers I'm thinking about, they're physically able to stand, and there's nothing that's telling them, oh, it's too difficult to stand. So capability isn't a problem. Let's cross that off our list. Opportunity. Is it about opportunity? Well, actually a lot of the time it is. Let's say we all wanted to stand and do this workshop standing up. What's the infrastructure of the room? What does the equipment around us tell us to do? It's actually, look, we've all got seats to sit at. But there's nothing that really encourages you to stand up. So I'm going to say there's limited physical opportunity to stand while you're at work. As was mentioned, the notion of norms. Looking at this room, almost everyone is sitting down. So it's clearly the norm within this room to be sitting. So I can say actually there's limited social opportunity for people to stand at work. Is motivation a problem? Well, actually I think it is. I think people don't know enough about the importance of standing at work. In other words, there's a problem in reflective motivation. People don't know enough, they're not motivated, they don't want to stand as much as they should. And also there's a problem of limited automatic motivation, in that people haven't developed routines or habits of standing. That is, it hasn't become something that they just do automatically and instinctively in the same way that they do when they're sitting. So that's my behavioural diagnosis for the problem of trying to promote standing in the office. Now it's over to you. What I'd like you to do now is leave your original intervention idea to one side, and now I want you to start afresh with that exact same behaviour. The first thing I want you to do is conduct a behavioural diagnosis, in other words a combi analysis. And I want you to think, is the behavioural problem that you're trying to solve, is it a problem of capability, opportunity, or motivation, or some combination of all of those? Okay, so motivation and volition earlier. The way that motivation and volition maps onto this model, the combi model, is that volition relates to capability and opportunity. They are two elements of kind of volition in terms of their, it's about whether or not you can act on your intentions. Another point, I was talking about motivation within the motivation and volition model, and I was talking about motivation as being where we actually want to do something. Now motivation within the combi model is defined not as conscious motivation, but as all internal processes that energise our behaviour. So it could be that we can change someone's behaviour through automatic motivation, and I'll be coming on to this later, for example through nudging people. So we've changed their behaviour through motivation, but it's not the same as consciously kind of changing their minds. Another point that it sounds like I may not have made particularly adequately is that when I said earlier that the best way to change diet and physical activity is through volitional strategies, I stand by that, but I wasn't trying to say that you should never give people information about the importance of doing a behaviour. What I'm trying to say is that you need to start with this kind of analysis, and if, as I'll come on to later, if the problem is, for example, about a lack of reflective motivation, in other words, people don't know about the importance of doing the behaviour and of why they should change, then actually giving them information may work particularly well. But my point is that you should never go into an intervention, into the intervention design process saying, right, I'm going to give people information about this behaviour and that's what's going to change their behaviour, because sometimes it might do, other times it might not, depending on the capability, opportunity and motivation analysis. So would anyone like to share their combi analysis? We've heard from these two groups over here. Was that a hand up or was that a scratch? Okay, someone was scratching there. One of the groups over here, please. No, stop picking people. Okay, group at the back. Could someone please explain, you were looking at snacking, was that right? Or food and drink consumption? Yes. Did you manage to do a combi analysis? Okay, now again, I'm not asking you to do this because I'm going to say it's wrong, I'm not going to say it's right. I just want you to have experience of going through this process. So could you possibly share with us the kind of barriers that you think might exist to changing behaviour when it comes to capability, opportunity and motivation?
So, our design outcome is for the staff to get up, walk, and somewhere else in the pantry or in a designated area.
Okay.
And then, so what kind of behavior that needs to be changed? Prolonged sitting and eating at the same time. Yeah. And then, so what? So the behavioral problems that we see is physical opportunity. So food is readily available, say it's within arm's reach, our desks. And then social opportunity. So it's like it's a norm in the office that everyone just eat in the desk. And then sort of motivation. So when an employee is stressed, he or she just eats sweets to just to pacify him or herself. Just like a comfort food.
Okay, excellent, excellent. So you've gone through that process and you're now starting to talk about what some of the problems may be that's supporting that behaviour. And you mentioned some really important points, so about eating at your desk, physical opportunity. And what's interesting in your case is you've gone through behaviour that people are doing, a health risk behaviour that they shouldn't be doing. So what you're doing in your combi analysis, you're trying to look at what supports the behaviour that you could potentially disrupt. So you talked about the physical opportunity, and you're perfectly right, that if someone has a snack in front of you, in front of them, often it's just too easy to reach for that snack. You also talked about the social opportunity in terms of there being a norm around snacking or it being socially acceptable. And the last point was about, was it reflective non-reflective motivation, in that actually people are doing this out of habit. So that immediately, you're now moving on to, okay, so that's what needs to change. So the next step that we're going to be talking about later is actually how do you go about bringing about change in those. But what you can see from having done that analysis, you're now starting to focus in on these are the things that we need to change. Rather than just saying, well, we're going to try and stop people eating snacks at their desk, and then going on to what intervention is best. You've gone through this process and you've arrived at an analysis of what the problem may be. So hopefully everyone found that a useful exercise. One important caveat that I should point out here is, what I have just asked you to do is probably fundamentally what you should not do when it comes to intervention design. What I mean by that is, I've asked you to run a combi analysis based on what you think the problems are. Now that goes back to the whole assumptions thing. Obviously I couldn't ask you to go away, consult some evidence, speak to some experts and then come back all within 20 minutes. But that was just an exercise in familiarising yourself with the combi model and going through this analysis process. But actually, when we think about doing a combi analysis, we shouldn't just base it on our own assumptions and our own preconceptions. So this is where, when we do our combi analysis, we need to make best use of the evidence that is available to us. In other words, what people often fail to do is involve the people for whom the behaviour is most relevant within the intervention design process. They think, well, I know why people are doing this behaviour, so from my combi analysis, I've arrived at this, so I'm going to develop an intervention. But by doing that, you're neglecting the experiences, the beliefs, the values of people whose behaviour you are trying to change. So one of the important things you should do as part of the intervention design process is get some evidence from the people whose behaviour you're trying to change. Try and find out from them, what are the barriers? Is it capability, opportunity and motivation? What are their priorities as well? As I mentioned, if you're trying to change workplace health behaviour, actually for a lot of people, for employees, they don't necessarily see the workplace as a kind of arena for health behaviour. They just see it as somewhere that they have to go and work and then go home. So actually maybe they're not going to be thinking about health and so on. But you as an employer or an intervention developer may think that they value health in exactly the same way as you do. That's why it's important to talk to people. Try and find out what their priorities are. Are there competing behaviours? As I said before, if you're trying to do an important piece of work, actually maybe your health isn't so important to you at that point. So you need to collect evidence regarding the potential barriers, the capability, opportunity and motivation. And in an ideal world, you would collect your own evidence through, for example, doing experiments with people whose behaviour you're trying to change, administering surveys, doing interviews, focus groups, all of this, and so on. In other words, you need to try and get into the participants' world, try and experience things the way they're experiencing it, so that you have a better insight into what the problem is for them in particular. I must point this out though. What some people think that means is, just go and ask people what the barriers are. Now that's better than not asking people what the barriers are. But often, just by asking people, well, the problem is if you ask people what the barriers are, you don't always get reliable information on what those barriers are. I'm thinking particularly about, for example, when you interview people or when you do focus group sessions. The reason for this is there's this notion of what we in psychology call social desirability. If you go in and interview someone one-to-one, are they really going to admit to some of what they see as the more embarrassing things that they do in their everyday lives? Are they going to talk about, for example, if you go in and say, I'm doing some research on why sitting's so bad for you, how long do you sit for? Actually, they probably won't say, well, I spend the entire day sitting down. They're probably going to say, well, I do try and do this, I do try and do that. It's a kind of reactant to the situation. It's a way of presenting yourself in a particular way that means that you're not seen in a negative light, or you are seen in a positive light. And this is quite natural, that people will engage in these processes, because an interview, a focus group, is essentially a social situation, and you don't want to come across in a negative light. It may be that people unwittingly give you inaccurate information on the barriers. This is a really important point, that often people don't know what the barriers to their behaviour are. And if you ask them, they will come up with theories about what's important. Or they might come up with some kind of rationalisations or justifications of what they do. So for example, if you said to someone, why do you eat chocolate? Why do you eat snacks during the day at work? They might say, well, actually there's a vending machine down the corridor. I just find it really easy to go there, and it's just so easy, like, it's so simple. If that wasn't there, I wouldn't do that. So then you remove the vending machine, and you find that actually they're going up the floor to another vending machine. So in other words, what they have told you is one of the barriers, the availability, or the opportunity to do the behaviour. When you remove it, you find out that they're still doing the behaviour. Now that doesn't mean they've lied to you, it just means that you've got a theory from them as to why they do what they do. And essentially what I'm trying to say is people don't always have insight into why they're doing what they're doing. This is particularly the case when it comes to non-reflective or automatic motivation. Automatic motivational processes are those that occur automatically, and we might not have insight into why we're doing them. So you can't just ask someone, did you do something, say, automatically, or did you do something, or what was the reason for doing this, if actually they're being driven by processes that bypass their conscious thoughts. So really, although you should speak to the people for whom the behaviour is relevant, you need to have other potential sources of evidence. You need to get evidence for other people for whom the behaviour is relevant. If it's a workplace health promotion intervention, speak to employers, speak to managers. What are their kind of theories about why the behaviour is occurring? All of this just gives you more information, more ammunition for your combi analysis. Of course, the other thing that you should look at ideally is research studies. These, as long as the research studies are generalisable to your particular target population, research studies give you scientific evidence regarding what the barriers may be. So it might be, for example, that you've found the Mickey et al. Study that showed you that actually volitional strategies seem to work in changing behaviour. Given that volition is about capability and opportunity, you could conclude that from that it's likely that one of the barriers for people, or one of the things that facilitate unhealthy behaviours, for example, are capability and opportunity. So it's not just that you should speak to people themselves, you should also look at the scientific research. Something else, you could do, say, a site visit. Go there yourself to wherever, to the workplace that you're trying to change the behaviour, because there may be clues within the environment as to why people might be doing something that they shouldn't be doing, or they may not be doing something that they should be doing. These are all just sources of evidence. But my point here is that you shouldn't just base it on your own assumptions. The other thing that you can do, ask the experts. There will be people who, for example, have been spending years studying particular behaviours, so ask them about what they think the barriers are. It may be that they have better information on these non-reflective processes than people do themselves. So this is a very quick group test, but I'd just like you to think about the other sources of evidence that you could use for your particular behaviour that you've been discussing so far. So we'll just have 5 minutes for this. I'd like you to think, what other sources of evidence can you use to inform your combi analysis? there any group that has thought of a source that they didn't consult the first time round? That there are additional sources that they can think of? So essentially, has anyone written anything down in response to this particular task?
Other sources.
Do you find any other sources? Can you think of any other sources? Yes?
Not many beyond what you had mentioned in terms of the literature and things like that, but what in terms of the water consumption problem, we have been discussing getting information about vending machines, content of vending machines, where vending machines are placed, so
Yeah.
from some sort of infrastructure body at the university level, for instance, or the workplace.
Okay. I probably should have clarified. What I meant by other sources, I meant sources that you didn't consult when you did your combi analysis a few minutes ago. But that's a very valid point, actually. So what you would do, rather than just base this on your own reading of the situation, your own self-directed or self-informed combi analysis, is, for your example of the vending machines, you would actually go and inspect the vending machines themselves. So hopefully that's been a useful exercise in showing you that there are other sources that you should consider when you're coming up with an intervention, not just your own preconceptions. And that goes back to the point I was making earlier, that you shouldn't just base this on your own assumptions. Okay, now I just want to go off on a slight bit of a tangent, but just to pick up on that point I was making about non-reflective determinants of people's behaviour. I mentioned that you can't always get the information you need in terms of determining barriers to behaviour, specifically or especially for non-reflective motivation, by just talking to people. So now I just want to share some insights from recent research findings that show that this is the case, that often people do things that seem to be determined by their environment rather than themselves. Now the first finding that I want to share with you, I mentioned the active building study earlier, whereby people are tracked throughout their day with accelerometers. Now actually what the researchers were interested in was, does the distance between where an office worker is based and certain predicted hotspots throughout the office building, for example the toilets, the refreshment point and so on, does the distance determine people's level of physical activity? Actually they found a really interesting finding, and as I should probably point out these are all preliminary findings because they're still analysing the data, but this was one of the first to come out. That actually there was a relationship between how close someone perceived themselves to be to a point at which they could get tea and coffee and the amount of time that they spent standing in their day. And in fact there was a 2-hour advantage, in other words people who rated themselves as sitting nearer to where the tea and coffee is kept within the office, they actually stood for 2 hours longer than all other office workers. Now that for me strikes me as a really counterintuitive finding, that you'd expect that people who sit at the other end of the corridor, they have to stand for longer because they have to stand up and go over to the coffee spot, make themselves a coffee and then walk back to their desk. But actually what's interesting about this is, firstly, I think what's interesting about it is it tells you about human behaviour and it tells you about a non-reflective influence on human behaviour in that actually people are adapting to the distance that they have to move from their desk to the tea and coffee spot. And actually, and this was based on, now some of these data came from UCL and our department, what you see within our department is the people who are less, or who are further away from the tea and coffee spots, they actually kind of club together. So there's a group of say 4 of them, and one person will go and make 4 cups of tea and then go back to the desk. And then the next time round, it's someone else's turn. So actually they're only making 1 trip, so they're standing for less long than someone who is closer to the tea and coffee spot. Something else that I think from my own experience, because my office is opposite the kitchen, I think because I can see my office and I can see my desk, I feel I can return to it quite easily, rather than thinking, well, it's all the way down the corridor, so I don't mind being away from my desk for so long, if you see what I mean. But these are all things that occur without us consciously necessarily being aware of what we're doing or why we're doing them. There's also a researcher called Frank Eves who works in the UK and does a lot of work on stair climbing. Now what he's found is less counterintuitive, but it's nonetheless very interesting, that he has found And he has done studies of millions of people climbing stairs, in which he and a researcher just stand in a shopping mall at the bottom of some stairs and observe who actually climbs up the stairs or takes the escalator. Now, you'll probably be underwhelmed by these findings at first, that people who don't use the stairs so much tend to be heavier, people who are over 60 tend to use the stairs less, and people with luggage tend to use the stairs less. The reason that I think this is an important finding is it actually works through non-reflective motivation. Because for these people, there's a greater physical cost in using the stairs. It's not just that they think, oh, I can't be bothered to climb the stairs. Actually, there's a greater physical cost for them. And those people whose leg muscles are less strong, they are less likely to climb the stairs. And the reason for that, the reason all of these things work in predicting stair avoidance is, it's actually the physical cost for you to climb the stairs predicts how steep you perceive the stairs to be. And the way that Frank has done research on this, he's got people, he's got this device, a kind of plate, whereby people put their hand on it at the bottom of the stairs and they have to adjust it to what they think the incline of the stairs is. And you find that people who have more weight on them or less strong muscles in their legs, they actually position the stairs, when on the plate they actually put their hand at a steeper angle. So they actually, if you might get people saying, actually I think this is, through what they're doing in terms of their hand on the plate, they're mapping out a kind of 45-degree incline, when in fact the stairs themselves are only, say, 20 degrees. So in other words, this is all working through non-reflective processes, that it's about people's perceptions, and these aren't conscious perceptions. If you ask someone how steep the stairs are, they wouldn't be able to tell you so well as if you got them to use a plate to judge. So do you see the point that I'm making here? All of this is stuff that occurs on a subconscious level. And it's not simply the case that telling someone, for example, that they should use the stairs would work in this instance, because the problem is that there's a greater physical cost to doing that behaviour. I thought I'd remove this, but anyway, this is just something saying that we need to be careful about, if we're going to try and change the behaviour, how we go about doing that. In that, if you give someone a prompt that says that they should use the stairs rather than using the lift, where you place that prompt will determine whether or not they do the behaviour. Now this is intuitive, in that if you place a sign saying please use the stairs within a lift, it's less effective than if you put it at the bottom of the stairs, or the point at which people make that choice. Now what's important here is it's not necessarily about reflective motivation. You're not persuading people to kind of choose the stairs, but actually what's happening here is it's psychologically different to be in a lift and to decide to exit the lift and go up the stairs than it is to be at the point at which the lift is here and the stairs are there and make your choice at that point. So this goes to show again, it's not about conscious motivation, it's about non-reflective or automatic motivation. And people themselves often don't have insight into these processes. And so, I really should have changed this, a few typos here. Changing people's attitudes and beliefs may not change their behaviours. So this is a point on which I want to talk about nudge. That nudging, it's a way of engaging non-reflective or automatic processes so that you change behaviour. Now this is a famous example that Frank often cites, given that it's about stair use. This was something that I think was done in Sweden, whereby what you typically find is that people take the escalator, they don't take the stairs. But what a group of people did was they painted a piano on the stairs. And every time you walked on the stair, that made a tone that corresponded to the note on the piano. So if you stood on, I'm trying to think of my music theory now, okay, if you stood here, that will play a C, and so on. So actually as people are walking up the stairs, they're kind of making music. Now the way this works is that you haven't told people, go and do this behaviour, you've just made it more appealing on an emotive level. So it's through non-reflection that you're trying to change behaviour. And here you see something that you could probably learn from when it comes to Kent Bridge Station. These are people, many more people walking up the stairs than are using the escalator. And that is a complete reverse of what you usually see. Where the stairs look a bit boring or look just as boring as the escalator, people will use the escalator. But where there's a bit more fun involved, they're likely to use your fun alternative. So again, you haven't changed their minds so much, You've just got them to engage with it on a more emotive level. This one, I had to show this, and luckily no one's eating. This is something that, when I first encountered it, I thought it was genius. This is about nudging. This is a gentleman's urinal. This is a little picture of a fly. Now the way this works, I think you all get the impression, but when you're standing there you think, what's that? And you aim at that. And actually, it's been claimed that this has reduced, so should we say, spillage by 80% in these toilets. And that's really important. Joking aside, that's important when it comes to health behaviour change, because you've achieved a public health outcome of having safer and less kind of toxic environments, and all you've done, you haven't put up a poster saying, please aim carefully, blah, blah, blah. You've just painted this little fly on the toilet. And this is the case in Holland. Anywhere you go in Holland, you see it, and it always makes me smile. So these are examples of nudges. These are things that work by changing behaviour, but you haven't really done anything to incentivise the behaviour. You haven't changed people's minds. You've just changed aspects of the environment in a way that bypasses conscious motivation, but nonetheless brings about a change in behaviour. For one thing I want to say about nudges, I want to emphasise that the people who are keen followers of nudge don't always do. This stuff only works if non-reflective motivation is a problem or is a way to change behaviour. If the problem is that people don't realise that they should do a behaviour, it may be that nudging won't work. So yes, by all means use nudges in your interventions, but only as a way to change non-reflective motivation. So nudge should come with a kind of health warning that it's not a magic bullet, as a lot of politicians in the UK and US think. It's not the case that it can be used for everything. It does have its uses in particular situations, but you must use it appropriately when you've done a combi analysis and you want to bring about change through non-reflective motivation. Okay, so I've covered the combi model. Now, the next layer of the behaviour change wheel, you remember I was talking about that about an hour ago or so, are the intervention functions. People often kind of neglect this, and this is another implicit assumption that people have, that you move from knowing what the problem is to going about changing behaviour. But in fact, there are different ways to change behaviour. And the behaviour change wheel specifies that there are 9 distinct ways to change behaviour. The first is through education. And this kind of marries up with what I was saying earlier about the traditional way that we try and change behaviour. We give people information. Education is essentially about increasing knowledge or understanding regarding the behaviour. So, for example, within the workplace, you might provide information to promote healthy eating. Another function is persuasion. Now, within the behaviour change wheel, this is separate from education in that it's not about giving people information to educate them, but it's actually about using communication to induce positive or negative feelings to stimulate action. So it kind of, again, bypasses that conscious thought process. So using imagery to motivate stair climbing in the way that I've just shown you, that would count as persuasion according to the behaviour change wheel. Another function, incentivization, whereby your intervention is based on creating the expectation that doing a particular behaviour will lead to a reward. So, for example, using a prize draw to induce a stop smoking attempt. Fourth function, and these aren't presented in any order, by the way. These aren't in order of preference or anything. Another function is coercion, whereby instead of creating an expectation of reward for doing the wanted behaviour, you create an expectation that there will be some cost incurred or some punishment for doing the behaviour that isn't wanted. So something like raising the price of unhealthy foods at work in that vending machine would be an example of coercion. Training. This is where you try and train people in the skills that they need to do the behaviour. So, for example, I've been talking about standing in the office environment. One way to encourage that is by giving people standing desks or sit-stand workstations. But you need to train people in how to use them. Because if they don't have the skills necessary to do the behaviour, you won't be successful in changing the behaviour. Restriction. This is about using rules to reduce or increase the opportunities to do a behaviour, such as the smoking ban in the workplace. One thing I want to add about this is, one of the reasons, going back to nudge, one of the reasons why people in policy-making circles and in government, in the UK at least, are so keen on nudge is that it seems like it's a way to change people's behaviour without really restricting what they're doing. So it's a kind of soft, voluntary way to change behaviour. Because there's all this kind of political rhetoric around what's in the UK called the nanny state, whereby the state is kind of nannying you and telling you should do this or you shouldn't do that. But actually what's been shown is that some people actually appreciate being restricted in their choices. That people, for example, who smoke, a lot of them did actually support the smoking ban in public places that came about in 2007 in the UK, precisely because it limited their opportunity to smoke in a public place. And by doing that, it didn't mean that they were likely to go and smoke elsewhere, it meant that they cut down on the amount that they smoked. And a lot of people did actually cut down on smoking. So it's not the case, as a politician would have you believe, that people don't like restriction. In certain circumstances, restriction is a very effective way to change behaviour. But it must be an acceptable way to change behaviour. And I'll come on to acceptability shortly. The last three intervention functions. Environmental restructuring. This is where you change elements of the physical environment or the social environment so as to make the behaviour more accessible. So, for example, providing that sit-stand workstation that I mentioned. Modelling is about providing an example for people to aspire to or imitate. I don't know about here, but at UCL we have this fantastic video showing employees engaging in correct safety procedures. It also shows, it's a real, it's kind of infamous at UCL, this video, because it shows one unfortunate person who decided that he would make toast at his desk, and he puts his toaster in the drawer, puts the toast in, puts the bread in, and then walks away, and unfortunately the entire building catches fire. Personally, I don't think that's going to work in changing people's behaviour, but at the very least it's memorable. But nonetheless, modelling is a way to change behaviour. And lastly, enablement. Personally, I think this is the kind of most weakly defined aspect of the behaviour change wheel, or the intervention functions. But what it essentially means is it's about increasing someone's means or reducing their barriers to it so that you increase their capability or opportunity, and doing that in a way which goes beyond training, environmental restructuring and all of the other elements. Now, I can see people keenly writing this down. All of this is within the Behaviour Change Wheel paper that I mentioned earlier. Google it, Behaviour Change Wheel 2011. All of this is in there. So an example of enablement is just advising people on places to walk at the work site, or kind of sitting people down and giving them a consultation on how they could go about changing their behaviour. So they are the 9 ways that you can go about changing people's behaviour. Now next, I apologise for the stretched nature of this. You're just going to have to trust me on this, but what this slide shows us is what is mapping the combi analysis that you've done onto the appropriate intervention functions. So for example, going back to what you've done earlier, if you have noted that a problem of why people aren't doing the behaviour is because they lack the psychological capability, so here represented by CPS, then, according to the Behaviour Change Wheel, which is the best evidence that we have, the best way to go about targeting behaviour change is through education, training, or enablement. So what you can see from this is how you go about moving from your combi analysis to designing an intervention that uses the function that's most likely to bring about behaviour change. So let's apply that to my example. So I mentioned earlier, I'm trying to promote standing at work. I've already noted that capability is not a problem. People are physically capable, they're psychologically capable, so the problem is about opportunity. And I say it's about physical opportunity, the environment not being conducive, it's about social opportunity, and it's about motivation. People might not have the reflective motivation to do it, and they don't have habits and routines for doing it. So, tracing these elements of the model onto the intervention functions leads me to think that these would be 3 ways to change behaviour. That I should do an intervention that includes an element of environmental restructuring, because that will target physical opportunity and automatic motivation. I'll include some education in there, because that will target reflective motivation. And I will include enablement as well, to target automatic motivation and physical and social opportunity. So what does that lead me to? Well, here's my idea for how I'm going to promote standing at work. I'm going to give people sit-stand desks. That's a form of environmental restructuring. I'm also going to provide information on the importance of standing more at work and reducing sitting. I'm going to do that via a poster and email campaign. That's my form of education. And lastly, I'm going to deliver the enablement component of the intervention by having individual consultations with someone with an employer or physical activity specialist. And I'm also going to give each of my employees the opportunity to get feedback on their standing and sitting time by fitting them with an accelerometer and then bringing them in for the individual consultations and going over their feedback with them and identifying areas in which they can stand more. So there's my intervention that I've arrived at. And the way that I've arrived at it is systematically, starting with a combi analysis, then moving from combi analysis to choosing the most appropriate intervention functions. So on that note, I would like you to go back to the intervention that you were planning. I want you to identify which intervention functions are most appropriate to use, and I'll go back to that slide in a second. And now I want you to think in more detail about exactly what you're going to do and what the function of your intervention will be. And also I'd like you to start fleshing out the details of your intervention. So for this, I will give you, let's say, 10 minutes to go through that. Sorry, 15 minutes. Is that okay with everyone? Okay. And okay, now, as I said, I'm not in the business of kind of getting everyone to share their interventions. It's just that I want you to have experience of going through this process. So I'm not going to ask you to share what you've done here, but I will be coming back to it shortly. One thing I do want to mention before, well, essentially one thing I want to mention that I haven't mentioned so far is the notion of initiation versus maintenance. This is a key issue, and apologies to anyone who was at my Habit talk last week. It's essentially a recycled slide. This is a key issue within the behaviour change literature, that often when we're thinking about changing behaviour, we only give enough thought to what happens at the start. So getting people to, if you think of it like trying to get people to run a marathon, once people have crossed the start line, we just kind of walk away and say, okay, they're going to be fine, they'll run that marathon. The problem then is that as a result of this approach, many interventions have only short-term effects. And if you were to look at a graph of people's behaviour, you find that there's an initial spike in enthusiasm for the behaviour that you're promoting. People start doing the behaviour, then they gradually tail off. And you find a few months later, if you were to go back, they've either gone back to their baseline, or for some unfortunate people, their behaviour becomes worse than it was in the first case. So the problem that we have when it comes to behaviour change is that we need to build in some kind of mechanism for maintaining the behaviour. And so I want you to think about your intervention. Have you developed an intervention so far that is very much based on the intervention that you've delivered or the intervention that you're designing? Or is it the case that you've got something that you think that when you withdraw your intervention, if you need to withdraw the intervention, that behaviour is likely to be self-sustaining or not? I mean, this will depend on what your behaviour is, but I think you've all chosen behaviours which are repeated. I mean, another workplace health behaviour that I haven't touched on is, for example, going for health screening. If your employer offers you health screening or a vaccine, it's a very important behaviour, but it only occurs every once in a while. Whereas that's completely different to, say, sedentary behaviour, where every day we're faced with this challenge of sitting too long and needing to stand. So given that we're all focusing on behaviours that need to change in the long term, repeated behaviours, I'd just like to talk a little bit about my kind of pet interest, which is in habit formation. Again, those of you at the talk last week will know all about this, hopefully. But from a psychological point of view, when we talk about habit formation, we're talking about the formation of an association between a particular situation and a behaviour that we do in that situation. The way we develop that association is by repeatedly doing the behaviour in that situation. So, for example, let's say I start a new job. In fact, let's apply this to what's going on here, actually. This, for me, is the first time I've been to Singapore and worked in this particular public health school, and I find that when I enter my office, there's the rather unappealing desk and chair in front of me, and apologies to the people who helped set up my visit, but there's also a filing cabinet which I find to be quite conducive to standing. So I think, great, so the first day I got here, I put my laptop on the filing cabinet and used that as a kind of makeshift sit-stand workstation. Now, if each time I come into work, the first few times I repeatedly put my laptop on the filing cabinet and start working there, what happens is that I develop an association between the behaviour or between encountering my office and my behavioural response to that, which is to put my laptop on the filing cabinet. And what happens is, as long as I experience that to be a satisfactory event for my health and for the purposes that I'm interested in, I'm going to keep doing the behaviour. And each time I do the behaviour, that strengthens that association between arriving in my office and getting my laptop and putting it on the filing cabinet. And that association becomes so strong to the point whereby encountering my office door and opening that door is sufficient for me to get my laptop out and plonk it on the filing cabinet. In other words, starting to use the filing cabinet as a standing workstation has become a habit. It's something which is now being prompted by the environment, an environmental cue of walking through the office door, and I no longer have to think about doing it. So this is something that can maintain behaviour, at least in theory, that if you get someone to keep doing a behaviour each time they encounter a context, then that should lead to the development of habit. And the reason that that's so useful is, if you've given someone an intervention that is very intensive or based on you being there to deliver it, you should have some component that means that the behaviour will become self-sustaining. And if you can create a habit or habits as part of your intervention, then when you step back and let people do their own behaviours, they're likely to keep doing the behaviour that you've encouraged and not likely to lapse back into what they were doing beforehand. Interestingly enough, there's something to be said about the context dependence of habit. In that I know as soon as I go back to London and walk through my office door there, I'm going to go straight back to the habits that I've developed in London because I have such a strong habit for sitting down in London. So whereas I might have formed a habit for standing here in Singapore, and the next time I come to Singapore, if I have the same office, I'm likely to stand again because I've formed a habit. When I return to my old environment, I'm likely to go back to the old pattern of behaviour that I've done. So this tells us that we should get people to start doing the behaviours automatically by forming a habit in response to a cue that is likely to stay in their environment when you withdraw the intervention. And I just wanted to share some insights from a study that we did a few years ago that evaluated a habit-based intervention. And what we found was, this was an intervention in which people were given some tips on things that they could do to manage their weight. So they were about diet and physical activity, and they weren't based on, the tips weren't based on doing things at work, but actually people spontaneously adopted these behaviours at work, and it seems that the stability of the workplace context was such that they were best able to sustain their behaviours at work. So for example, when it came to dietary habits, we had someone who started bringing in fruit and rice cakes to work, and they found that the chocolate bar and the chips that they previously used to eat completely went out of the window. Someone else saying, I would have my breakfast as soon as I got into the office. That was constant. So now they've set up a regular pattern for doing things within the workplace. What's nice about this is, look, it's just as soon as I got into the office, that's their cue. So they've created a habit for doing something when they go into the office. Now, so long as they're not sacked, as long as they keep working in that office, then hopefully they should keep eating their breakfast when they go into the office. So we've created something, although we didn't actually try to create workplace-specific habits, the routineness, the stability of the workplace environment seems to lend itself to the creation of these habits. And likewise for physical activity. People were saying, well, every lunchtime I'd leave my desk and go for a walk. Someone else saying that they would walk from work to home. So all of these involve cues that occur regularly in the workplace. But actually, some of these people who said that they'd form these workplace habits, at the weekend, when life is generally less structured, they were not so able to do the behaviours. Because then the behaviour is not automatic, it requires conscious effort again. So although we might not be able to change people's behaviour in the long term outside of the workplace environment so well, what this tells us is that the predictability of people's work days and the routines, the settings in which they work, actually lend themselves quite well to habit formation. And here's an example which mirrors what I was saying about when I returned to London after 2 weeks here, that my context change of being in Singapore has led me to stand more. But when I go back to my old context, I'm likely to go back to what I was doing before. But this has been used for kind of positive purposes here, in that someone who has formed a habit for eating healthily at work has said that when they went on holiday for 2 weeks and their context changed, actually their new positive habit was disrupted. But once they got back to work, it reinstated their positive, healthy habit. So this just goes to show it's something you could definitely work into any behaviour change intervention. So I'm not sure we need to do this as a group task, but
Eric had a question.
oh yes, yeah.
So how do you measure habit change other than putting a camera on them or something?
Very good question. The best measure that we have, it's a real problem because, as I said earlier, it's usually assumed that people can't reflect on non-reflective processes. But what we think that they can reflect on are the kind of symptoms of a non-reflective process. So if you say to someone, when you do this behaviour, are you able to do other things at once? Or when you do this behaviour, is it something that you start doing without thinking about it? Then you start to get their reflections on how they experience doing the behaviour, and you can infer from that that they have a habit. And that is the thinking behind the most commonly used measure within the research literature, which is called the Self-Report Habit Index, which sets out 12 items detailing whether or not the behaviour is done automatically, how frequently it's done, and there's also an item in there about self-identity. Is it relevant to you? Is it something that typifies you? Actually, I've done research that shows that you can whittle the Self-Report Habit Index down to 4 items that focus specifically on automaticity. Now, it's not an ideal measure, but it measures the it's more sensitive to the psychological process of habit, in other words, doing something automatically, than measures of behaviour. Because it might be that we do a behaviour repeatedly, but each time we do it, we're thinking about what we're doing. So think of, say, a classic case would be a doctor diagnosing patients or treating patients. Actually, the patient comes in and they do a diagnosis, they administer it to the patient and then they leave. But you wouldn't say that the doctor has formed a habit for diagnosing specific diseases. It might just be that everyone who's come in their door that day has the same disease. But they're actually putting the same conscious thought process into that. But let's say, for example, you had 20 patients with flu, and you had a doctor that had a habit for prescribing anti-flu medication and another one who thought carefully about what they did. If you only examine their behaviour, you find that all the patients come out with an anti-flu medication prescription, but actually one of the doctors has a habit, the other one doesn't. So that's why you can't infer things from their behaviour, you have to think about the psychological process. And the best thing that we've got is that automaticity measure.
And there's no external non-subject related.
No, well, people have developed kind of brain imaging type measures. Of course, they're not something that are very, very kind of easy or cost effective to use. The other thing that you can do, another way of detecting a habit is the way that habit is sometimes defined is that it becomes so automatic that people lose their sensitivity to the actual kind of value of doing the behaviour. So if you devalue the reward that is associated with the behaviour, do they keep doing it? A classic case of that was, a lot of the research on habit has been done in animals, and they've shown that actually you can train rats to press a lever so many times to get food, that if you inject them with something that makes the food really taste unpleasant and it makes them violently ill, for a certain amount of time they'll keep pressing that lever even though they're getting ill each time. So it's more a case that you can potentially detect habit by trying to change the behaviour and seeing if people can change it. But in terms of just trying to find out whether someone's got a habit without making any changes, unfortunately the best thing that we seem to have is a self-report measure. The other thing is that another way that's used to measure habit is you look at not only the frequency with which something is done, but how stable the context is. in that if you're doing something repeatedly and in a stable context, then it's likely you're going to be doing it habitually. But that only tells you about likelihood of habit, not necessarily how strong it is. Okay, I don't think we've got time for this particular task, but if there were time for it, I would encourage you to think about whether the intervention that you've developed is about initiation of behaviour change, or whether it's about maintenance. And if you've only put in elements that will initiate behaviour, then really you should add something about maintenance. Okay. Actually, I think we do have time for this. Let's have 5 minutes on this. And then after this, I'm going to ask you to share some of the intervention ideas that you've come up with. So I don't want you to only think about initiation and maintenance. I want you to bring together all of the ideas that you've had so far from the third task onwards and start thinking about what your intervention is, and hopefully you'll be willing to share it with the group, but you might want to put in some extra elements that target maintenance as well as initiation. One point I think I need to make, very good point that was just raised is, you don't always have to distinguish between initiation and maintenance. The point that was just discussed at the back was actually if your intervention includes, say, restriction, whereby you remove, let's say you ban cigarettes, then you don't need to talk about initiation or maintenance because you've changed the environment such that people no longer have the opportunity to do the behaviour. So it's not the case that you always need to think, okay, well, how am I going to target maintenance? What I wanted you to do was just think about this distinction between initiation and maintenance. Contemplate whether you might need to amend your intervention in any way, and if so, make amendments to that intervention. Did anyone actually find this distinction useful? Did anyone make any changes to their planned intervention as a result of this distinction? Did anyone add anything in or take anything out? No. Okay. Okay, well, I think we're heading to the big reveal. Would one group like to volunteer and describe the intervention that they've come up with, please? Okay, I'm going to have to pick. Group at the front. What did you come up with? If you wouldn't mind
So
sharing.
we are thinking about sanitary behavior.
Yes.
First, looking at one of the initiatives actually already done by another department. We have
Yes.
these gym balls for people to sit instead of a normal chair,
Yes.
which supposedly having some health benefit, and then they also ease bedding. So we thought of bringing this new equipment into a department.
Okay.
So
Could I just ask, what was the outcome of your combi analysis then? In terms of, this was about sitting time, was it?
This is about health benefit of changing a different city-wise. It's
Okay, yes.
It's still city.
Yeah. Oh, okay. So that's a really interesting behaviour. So you're trying to substitute sitting on a chair for sitting for kind of more active sitting.
Which you need to strike by a balance.
Yes, yeah. So you're turning sitting into an active behaviour. So your combi analysis.
So our comprehensive by using the capabilities as well. So there's no physical limitation. So that we mainly believe some people may think sitting in a chair is more comfy than trying to strike a balance. So based on this, we went into the chart that help us to determine maybe just one example for that. So we have three. So that considers psychological capability. So we use education, training, and enhancement based on the chart.
Yeah.
So for education, probably we'll elaborate on the benefits to show people what it's about. For the training, is like how to use discount equipment, and for the enhancement, I didn't really think about the things.
Yeah, and sorry, just to interrupt you, that's a really important point. It's not the case that you need to do all of the intervention functions that are relevant. The aim of the mapping of the intervention functions onto the combi analysis is it points you in the direction of particular interventions. Yeah, and sorry, one really important point that I forgot to make is for anything that you plan to do, you need to also do an analysis of whether it's likely to be feasible and acceptable within the environment. So, for example, it might be that you determine that you can stop smoking, you can stop people smoking through restriction, but actually it's not feasible for you to do that, or it wouldn't be acceptable to your target audience to try and restrict that behaviour. And it's really important that you consider acceptability, because if something isn't acceptable, then you might prompt what's called psychological reactance, whereby someone says, you're trying to control my behaviour, I'm not happy about this, I'm not going to go along with it. Anyway, sorry, going back to what you were saying.
So after we continue with what you are asking us to discuss regarding the initiation or maintenance, so we thought ours made more the initiation. After that, we don't know whether people can sustain this behavior, so we attempt to tune our interventions a little bit. So probably we are thinking of how do we make it this habit.
Yeah.
For example, that for a period of time, we do probably a charting or reporting, see how many people actually use how many hours.
Yeah.
So we reward the group that with the consistent behavior. So hopefully they can form a habit.
Yeah.
And that will flow into the maintenance phase of continuing this health behavior after we draw the other incentives.
Okay, excellent. That was a brilliant example. I think something that you've illustrated there is that you can't necessarily anticipate that your behaviour will lead to, your intervention will lead to maintenance. Something else that I haven't covered is, when it comes to developing any intervention, you need to go through a pilot phase, whereby you try out the intervention, and depending on how it works, whether it seems to be effective, whether it seems to be acceptable, feasible, and so on, you can then make changes to your intervention. And in fact, by going through that pilot phase, you can then go back to your combi analysis. So for example, taking your example of someone using an exercise ball, you might, on the basis of the best information available to you, say that actually physical capability is no problem. People can sit on this for a long time, because I've got a study from Australia that shows that people can use it, for example. But then you actually pilot it and you find that it's causing pain among people. So then you realise actually physical capability is a problem. So that means that you then go back to do your combi analysis, and you then might need to refine what you're doing. That makes the really important point that actually intervention design should be seen as iterative. It's not the case that you go through this process and you say, right, I've got it, that's going to work. You come out with something and then you need to pilot it and keep returning back to those earlier stages, so that you, when you come to the point at which you really do think you've got the effective intervention, it's based on pilot data, it's based on information about whether it's likely to be acceptable, feasible, and have any effect. Could I also ask this group at the front, does your intervention now look any different to the intervention you developed in the first instance?
Yes, we
Okay.
kind of look at how to sustain the effect. So
Yes.
it's more for maintenance.
Okay, brilliant. I'm glad you said yes. I did have a backup plan in case you said no. We've come up with exactly the same intervention, which was just to say, actually, at least you've all been exposed to a framework about how you think about doing this, and a systematic way to go about designing behaviour change intervention. But thankfully you said yes. Having gone through this process, you've now reconsidered the problem and thought about alternative ways to go about solving it. Unfortunately, due to time, I'm not going to have time for everyone to go through their interventions. Frankly, I think if I did, there'd be quite a few people probably who would say, no, they haven't changed it, so I'm going to quit while I'm ahead. And just move on to a very brief summary. So what I've shared with you today is not any great insight into how to change workplace health behaviour, in that I haven't told you the secret of changing behaviour. What I've shared with you is a framework by which you should go about thinking about the behaviour change process in a way that means that you optimise the likelihood that your intervention will be effective. There are essentially 4 steps in developing a behaviour change intervention. The first of which I didn't really touch on in so much depth, but you must select the behaviour that you want to change. I did mention that it's not enough to say that you want to change a health outcome and move from that to an intervention, because health outcomes are outcomes of behaviour. So you need to think about the behaviour. You need to specify the behaviour in as much detail as possible. Don't just think physical activity, think, for example, walking or standing or some other specific form of physical activity. Ideally, you would contextualise that behaviour. Think about who needs to do the behaviour, what is the behaviour, and in which context are they going to do the behaviour. I didn't cover all of that because of time, but nonetheless you move from that stage to saying, okay, I know exactly what the behaviour is that I want to change, now I need to do a combi analysis. I'm going to consider all of the evidence available to me, and if possible I'm going to collect more evidence to inform an analysis of whether the behavioural problem is one of capability, opportunity, and or motivation. Having done that, you can then move from your combi analysis to consider the function that you want your intervention to play. Having done that, you can then move to the stage of selecting the most appropriate intervention content. This step 4, there is so much more to be said about this in terms of selecting specific techniques to change behaviour. I only touched on behaviour change techniques very, very briefly when I was talking about techniques to bring about change at the volitional stage. There is an entire body of literature that has developed around this in health psychology in the last 6 years, and I can give you references if needed, but it's simply too much, I think, to cover that within this session. So this is more of an introductory session. Let's ignore that. I just wanted to cover this very, very quickly, that of course whenever you do an intervention, whenever you administer a behaviour change intervention, and I realise I may be preaching to the converted here, you must evaluate that intervention. So why should you do that? Well, actually, it increases the knowledge base, so that in future when someone else comes to do a combi analysis of that exact same behaviour that you've tried to change, it gives them an input into that analysis. They can say, well, actually these researchers tried doing this and it seemed to work, or it didn't seem to work. So if they've tried, for example, an intervention based on enhancing physical capability and it didn't work, that works in telling future researchers perhaps you shouldn't be trying to target physical capability. So in this respect, you can avoid people reinventing the wheel. Much as we all like obtaining research funding, it is such a waste of what is essentially taxpayers' money to do something that's already been done. As I said, it also provides an input into the combi analysis. Often when we talk about evaluation, the key question that people ask is, has my intervention worked? But actually, a point that I'd like you to take away from this is, by considering each of those processes, each of those stages that I've talked about, you can increase knowledge not only on what works, but actually how and why it might work. Or if something didn't work, you can actually contribute to knowledge about how or why it might not have worked. So for example, your physical capability intervention that you may have come up with, you could say not only does it not work, but we now know that an intervention based on physical capability does not work. So that helps future researchers. I probably don't need to tell anyone about this, but essentially, very quickly, how do you go about evaluating interventions? Well, essentially, you need to collect some information before you even administer an intervention, because in that way, it provides something that you can compare your post-intervention outcomes with. Of course, this is basic kind of trial evaluation methodology, but you should use the same sample at both time points. I've been involved I've been asked to work on projects whereby people have said, okay, we've got some great evidence showing this works, but actually they've taken a sample of people in a particular area where an information campaign was used, and then they've taken a completely different sample of people at a later point and said, look, we've showed changes in their attitudes and in their behaviour. Well, you've got a different sample at 2 time points, so you can't say that your intervention has necessarily brought about any changes because you don't have an adequate kind of control or baseline measure. Of course, you should try and use control groups in any trial design, because that allows you to rule out the influence of any extraneous variables. If you administer an intervention to increase walking, and you administer that in summer, and then you take your baseline measures, say in winter. Sorry, seasons I suppose don't really count here in Singapore, but let's say, imagine you're in the coldest parts of the UK, you administer an intervention in the winter when it's very cold outside, and then you take measures in the summer when it's very warm. Well, actually it might be the warmth of the environment which has caused that problem, which has caused the effect, and so by not having a control group, you don't have anything else to compare it to. I know from what's often seen as important from a scientific point of view, those priorities are not necessarily shared by people who, in say public health, who need to go out and administer an intervention and do it as quickly as possible and not bother with all this fluff about evaluation. So another way of doing this is to use what's called a step wedge design, whereby you have different clusters or different areas in which you want to administer your intervention, but actually you introduce your intervention to each area in a particular order, but you take measures from all all areas at baseline. So you can then say, actually, there's nothing stopping me from administering this intervention, but by giving it out gradually, I can tell that there have been more pronounced changes in those who received it earlier. So it's a more pragmatic way of going about evaluation. Okay, so grand conclusions. I've told you that behaviour is important to health, but too many interventions are based on the principle of it seemed like a good idea at the time. So you should use a systematic approach, which requires that you identify the behaviour you need to change, you identify what needs to change for the behaviour to occur, you then select intervention functions that are appropriate to your combi analysis. And you should also evaluate your interventions in a way that can contribute to knowledge. So that's everything I wanted to say, but I'm kind of almost contractually obliged by my colleagues at UCL to put a few adverts out now. As I mentioned, there is a week-long summer school happening in London in August this year, which is hosted by the world-leading experts in behaviour change, Professors Susan Mickey and Robert West. If they hadn't done their work, my talk would be completely different and not half as good as it has been, because they are really leading the field on this. So if you're interested, this is open to anyone. Please do go along to it. There are opportunities for you to work with these experts on a one-to-one basis to develop your expertise and knowledge in behaviour change. There's a link to it down there, but you can also email me, my email address to come. I've talked about the behaviour change wheel. I've told you to Google that paper. There's also now a book which goes over more or less everything I've said today and then a lot more. That book is available online as a kind of online version. There's also an e-book that's going to be coming out soon. And when I looked at it from Singapore, I think it's only around $7 to buy the book. So it's really useful and it's quite inexpensive. And lastly, as I said, I didn't even really touch on behaviour change techniques. These are the discrete units of interventions. There's been so much work done on this. I haven't had time to cover it, but I would strongly recommend anyone interested in this to look up the BCT taxonomy. In fact, if you go to this link, it's not up and running yet, but the authors, Susan Mickey and Robert West, are putting together a free online training program in using the behaviour change technique taxonomy to develop interventions and to specify the most important components of interventions. The way this fits in with what I was saying earlier is, actually when you found the intervention functions that you should use, you can then move to selecting the most appropriate behaviour change techniques that are available. I haven't had time to touch on that, but if you go to this website, if you buy the Behaviour Change Wheel book, you'll find out more about that. But that's everything I wanted to cover today. Thank you very much for your participation.